Welcome to Catholic Ethics and the Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Mike. I'll be the operator for our presentation today. Now, before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings. There will be a question and answer portion of the webinar. To submit a question, you should see an option in the lower portion of your screen to type in your questions as we move through the presentation. We are joined today by Nate Hibner, Director of Ethics for the Catholic Health Association. So at this time, I would like to turn the presentation over to Nate for opening remarks.
Thank you, Mike. A good day and welcome to all of you. Thank you for being with us today for part one of a special series presented by the Catholic Health Association at Georgetown University with the help of the Pellegrino Center for Bioethics. The program, as is mentioned, is titled Catholic Ethics and the Challenge of COVID-19. But before I introduce our speakers for the two-part that we have for today, I want us to remind ourselves that we're ever in the presence of God and that we say a quick prayer for all those who are suffering during this time. Merciful God, hear our fervent prayer for all who suffer from the coronavirus. May those who are infected receive the proper treatment and the comfort of your healing presence. May their caregivers, families, and neighbors be shielded from the onslaught of the virus. Give solace to those who grieve the loss of loved ones. Protect and guide those who strive to find a cure, that their work may conquer the disease and restore communities to wholeness and health. Help us to rise above fear. We ask all this through the intercession of Our Lady of Lourdes, in the name of your Son, Jesus, and the Holy Spirit, now and forever. Amen.
Amen.
We are pleased to be joined today by three distinguished presenters from the Georgetown University community. The first is Kevin Donovan, who is the director of the Pellegrino Center for Clinical Bioethics and a professor of pediatrics. He will be our moderator and our interlocutor for today's sessions. The first half hour will have Miles Sheehan, who is a lecturer at the Pellegrino Center, as well as the provincial delegate for Senior Jesuits Maryland and the USA Northeast provinces. The second half of our hour-long presentation will be joined by Alan Roberts, who is a professor of clinical medicine, associate medical director, and chair of the ethics committee at MedStar Georgetown University Hospital. Welcome to you all.
Thank you.
Today's event is divided into three 30-minute sessions in which you'll have time to submit questions to the presenters through the Q&A option at the bottom of your Zoom screen. In the first session, Miles and Kevin will be discussing DNR orders as they relate to COVID-19 patients. And in the second session, Alan and Kevin will discuss the reallocation of ventilators. So at this time, I wish to turn it over to Kevin and Miles to begin their discussion.
Thank you, Nate. I'm really delighted to have Dr. Sheehan with us. He's somewhat unique, even in the Pellegrino Center, because he is a physician, a clinical ethicist, as are most of us, but also a Jesuit with a great deal of experience, not just in medicine, but in geriatric medicine. We'll look at the next slide, if you will, Miles, and tell us what your objectives are for us today.
What I'd like to do is to take a look at some of our basic principles of ethical decision-making with Catholic healthcare ethics, and then apply those to the situation of resuscitation decisions in COVID-19 positive patients. In doing that, we need to look about what we know about CPR and in-hospital resuscitation even prior to the current crisis. Think a little bit about why people have cardiac arrest with COVID-19 patients and how that might affect their way we approach resuscitation. Consider some of those patients who are not candidates for CPR and for those whom it is not indicated. And then ensure that within your institutions that you have administrative backup and review. We don't want you to take what we say today and just do it on your own. You need to make sure you have a team.
Okay, let's start with some cases because it's clinical bioethics.
So the case is, let's pretend you're an administrator who sits on a Catholic hospital's COVID-19 response team. The hospital ICU director requests that the team issue a policy regarding the use of CPR and resuscitation on COVID-19 positive patients. Reasonably, the director is concerned about the ineffectiveness of resuscitation in some patients, as well as a risk of exposure of the virus to staff involved in resuscitation. How much you think about this?
Well, one of the problems that we've run into is the fact that some of the various protocols have just said it's an easy answer. You just shouldn't resuscitate these people.
And that's right, Kevin. And I think that that's absolutely the wrong approach. But we also need to realize that in-hospital cardiac arrest prior to COVID-19 was hardly a panacea, and that the lay public often overestimates how many people you think will be resuscitated. I think they think it's somewhere between 60 to 80%, whereas the latest figures in this source is from 2018, that about 20% survive with an in-hospital cardiac arrest. For those patients who are already on a ventilator or they had blood pressure medicine called pressors, that cut the survival rate in half, so just to 10%.
May I ask you to clarify? That cuts it in half, not because necessarily there's something bad about pressors or mechanical ventilation, but more bad about needing them?
It's because they're already so sick. The sicker the patient, the worse they do with the resuscitation. And that also, holds true with our COVID patients. So again, if 6 months ago somebody was terribly sick with a variety of causes, you could predict they're not going to do well for resuscitation. The same thing holds true now with COVID. In the hospital, the best settings we have with successful resuscitation is when someone's having myocardial ischemia, say like unstable angina, a myocardial infarction or a heart attack, or acute perioperative events. For instance, the beginning or the end of anesthesia is a particular time for arrhythmias. Those people usually are resuscitated and do fine. Patients who are sick do worse, as I just said. So those people who are septic, who have renal failure or have multi-organ failure, they're already doing poorly, and if they arrest, they don't do well. This is the point that you need to think a little bit about what is going on with each person. I don't believe, and I don't think most people do, that resuscitation needs to be offered to every person. That was the same way it was before COVID-19. It's not going to restore circulation and breathing, or there's chance of survival to discharge is vanishingly small. We can talk more about the conversation you have about that. But again, prior to COVID, there were situations where clinicians thought it was a bad idea to initiate resuscitation, and there are ways to discuss it. It has remained rare, however, that physicians would feel comfortable writing "do not attempt resuscitation" unilaterally. The preference has been for agreement with patients and surrogates.
How does COVID affect this then?
Well, I think that we take a look at, first, what is the underlying condition? And let's take a look at some of these scenarios, if that's okay. Imagine you have a previously healthy man in his 50s who's getting oxygen by face masks. Now, they measure his O2 sats and they're decreasing. He has some chest pain, the EKG shows changes, and then he goes into ventricular tachycardia and arrest. One situation. The second is you have an elderly lady in her early 90s who's getting oxygen by face mask. But prior to getting COVID, she has renal breast cancer, metastatic breast cancer, renal insufficiency, and heart failure. She suddenly loses consciousness and then is found to be in cardiac arrest. The third situation we can think about is a 40-year-old woman who with COVID has widespread organ failure, is maximally ventilated, and has refractory hypotension despite the use of 3 powerful intravenous pressors, norepinephrine, dopamine, and dobutamine. And then finally, let's think about an older patient of unknown age and history who shows up in your emergency room and arrests as they're wheeling him through the door. How much you think about these cases?
You're going to have to individualize your approach?
Yeah, and I think that that's really the take-home point. I guess there are 2 take-home points. One is no blanket refusal of COVID resuscitations. And the second is think about the cases carefully. Now, the man who has ischemia in the setting of COVID-19, it's not all that different than would have been 3 or 4 months ago. Chances are with ischemia, he would do relatively well with resuscitation. I think in that particular situation, it would be indicated. The elderly lady with the multiple comorbidities, well, if she showed up 6 months ago with, say, just a regular pneumonia, I think people would have thought twice about resuscitating her, not because she's in her 90s. The point isn't that she's in her 90s. The point is that she has heart failure, she has renal failure, and she has metastatic breast cancer. The chance of a successful resuscitation, much less successful discharge from the hospital, is very low. And so this is a situation where you need to think carefully about whether or not you would want to proceed with resuscitation. The third case of the young woman with the multi-organ failure and intractable hypotension, that is low blood pressure, she's dying. She's dying and she's getting maximal treatment possible with the 3 intravenous pressors. When her heart stops, she's died despite trying everything. I do not think that there is any likelihood that subjecting her to electrical shocks, pounding on her chest, the whole other stuff we do, would do anything, because in some ways we are in a way coding her by having her on all those medications right now. Now the final thing is the man in the emergency room is unknown. We don't know why he's there and why he's arrested. This guy should receive resuscitative efforts. Again, the presumption in favor of resuscitation is still there, but you need to look at each individual. In an absolute emergency where you don't know what's going on, you err on the side of preserving life. Next slide, please. Here's the thing that is different now, though, with the COVID. We need to talk about the virtue of temperance and not just rushing in to resuscitate somebody when a problem develops. I've been seeing some hospitals developing, and hopefully your facilities have them, of protocols that strictly limit the number of people who will respond. As you know, sometimes when a cardiac arrest or a code blue or whatever your hospital calls it, you can really have a mob scene in the room. That's not the best at any time, but now it's critical that you limit the number of people who respond. Why? Because there's an increased risk with chest compressions of aerosolization. If someone's getting intubated, again, that can lead to more aerosolization. So before you get into the room, those people who are the designated resuscitation team must use available PPE. Does this mean that you are going to waste some seconds to resuscitate the person? Yes. But at the same time, it is an appropriate precaution for those medical providers to preserve their health to the extent possible. There are a lot of other details to think about, like making sure the crash cart is kept outside the room in what we'd call a cold area, that you have a warm area where, say, blood gases get passed out and medications get passed in, whereas inside the room is the hot zone, and you want as little contact as possible with that room and with the individuals who are in it.
So Dr. Sheehan, this is really, I think, the crux of the matter for a lot of people who want to say, we just, shouldn't be exposing the medical caretakers to the risks of acquiring a COVID infection by putting people through CPR when we're really not sure of its benefits. Now, if you tell them to stand out in the hallway and don all the protective gear, that should give them increased safety. There's no guarantee of 100%. But is that a change that we are willing to make, and a balance in doing CPR on these patients, knowing full well that putting all that gear on is going to delay getting to them and probably risks making your CPR less effective?
I think it's a balance. If you look at the virtues, an excess of courage would have you run in. An excess of temperance would have you not care for anybody. I think the prudent approach is to try to make sure we have adequately protected as small a number of people as possible to do the resuscitation, and that we focus those resuscitative efforts on those people who are most likely to be resuscitated. The part about those 4 cases, I mean, the one that I would say is the obvious, of course he should be resuscitated, is the middle-aged man who is busy trying to have a heart attack in the setting of a COVID infection. The next part would be the man in the emergency room. Everyone who codes these days, we need to presume that they are COVID-19 positive because we can't be sure they're not. So again, those emergencies that happen and people just coming to the ER, places in the other parts of the hospital, I think we should look towards maximal protection.
And should we talk about DNRs in this setting as well?
Well, it's important that we try to do a little preventive ethics, and before people get intubated, and ideally while they're being admitted, although sometimes in the clinical situation they deteriorate before you can have a discussion. You want to talk about, do the people have an advance directive or a durable power of attorney or a healthcare proxy, whatever the instrument is in your particular locality. It's much more important now, and you can't just leave this to the person who is the clerk in the emergency room to ask that question. The doctors need to at least ask. And then again, and these aren't the easiest things, but to ask specifically about whether the patient or an appropriate surrogate, about would the person want to be transferred to the ICU? Would they want to be put on a ventilator? Would they want to be resuscitated? Just as prior to COVID, there were many people who did not want those things. It's important to find about it now. It's also worthwhile to make sure that you have the assistance, if at all possible, of a palliative care team. First, to help in those discussions, but also to make sure that those people who have chosen to forego transfer into the ICU or mechanical ventilation, that they get excellent care. With all times, and this time especially, to say I don't want to be intubated doesn't mean I don't want to be cared for and abandoned. So we have to understand that. And then you want to make sure that those wishes and decisions are documented carefully. You know, trying to learn how to talk in these situations, this might not be the best time for learning, but it's not a tough skill, and you can get it used to it relatively quickly. Just as we mentioned earlier, Kevin, I wasn't good at suturing when I was a medical student. I got very good at it when I was a house officer. So again, you can learn how to have the discussions. You know, start just to say, you know, this is a serious illness. Have you thought about your wishes in the event that you were to need to be ventilated or your heart would stop? Again, the lines seem blunt. It's rare people aren't thinking about it. It's made even harder because often you have to do this over the phone with the surrogate and not in person. But it's worth practicing and trying and talking, especially to your palliative care specialist, or if you have an ethics consultant to assist you in these discussions.
So Dr. Sheehan, one of the questions that we got was, who is the best equipped to have that discussion with the patient or the families?
Well, I think it's somebody who has some practice doing it. It is someone who is comfortable, and it's also someone who's willing to learn from others about the best way to have these discussions. Not every discussion is going to go perfectly, no matter how well you do it. But if you don't try, you're going to end up with the situation where you have people who are crashing from a respiratory standpoint, and no one ever asked. No one ever talked about what should be done. And particularly when we're trying to minimize exposure of healthcare workers while maximizing appropriate care, we really need to have these discussions.
Okay, let's talk about DNR on the next slide there.
So I'm hoping that people would get that you just don't make these decisions ad hoc, that it needs to be something that you're actively considering as a hospital policy at this moment, and that administration and legal needs to be involved in case for those decisions where it is decided that a do not attempt resuscitation order is indicated, that the hospital is willing to stand by you. It's best to have a policy and avoid the ad hoc so that it's done equitably and in a uniform manner. In other words, that you are looking as carefully as you can to avoid bias. That's why I've been careful to say you don't do it by age. You do look at underlying condition. You do look at how they're doing with the illness, but you're very careful, and that can include to take a look after the fact about what have we been deciding and did that make sense. We do need to make sure that the patient, if possible, but surrogates and family are informed and the conversation's carefully planned. You know, a question came up, when's the best time to do this conversation? I think ideally in the emergency room, but that might be too hard. I think whenever the situation presents, if it hasn't already been discussed, make sure you have the discussion. But I don't think a blanket do not attempt resuscitation is acceptable for all COVID-19 patients. As I said, the person in the center with myocardial ischemia, some other situations, they have a reasonable opportunity to be resuscitated. People who have severe organ failure, underlying comorbidities, they're much less likely. We knew about that prior to COVID. COVID just makes the situation worse and more dangerous.
All right, Dr. Sheehan, we've got a couple of questions that kind of go right to this point, because you did mention that patients maybe have chances that are vanishingly small, I think is the term you used, while they're on the vent and still don't have a DNR order in place. Now, traditionally, we've gone about this one way, which is we sit down and ask the family if they would like to place a DNR order. And sometimes they say, oh my gosh, we wouldn't want to put them through that. Frequently, however, they'd say, of course, we want them resuscitated. You know, we want them to get well. One response to this in the practice of medicine has been increasingly for doctors to just say, we are going to place a DNR order on your loved one, and just tell them rather than ask them.
I think
the middle way.
Well, and I think what I used to do, obviously, when I was practicing prior to this, is when one of my patients came in who, say, had advanced Alzheimer's disease and a pneumonia, is I didn't have a conversation telling the family what I wasn't going to do. I said, here is how I'm going to take care of your mother. We're going to admit her to the hospital. We're going to make sure she gets some extra oxygen. I'm going to start her some antibiotics. I need you to know that I think I'm very worried she's going to die. If she stops breathing or her heart stops, I think it's time for her to go to God, and I don't want to put her through all the aggressive stuff that the hospital has, and I don't recommend that. In other words, I think physicians are allowed to present a treatment plan and then have a discussion afterwards. So many times I saw residents or other physicians say, well, we don't want to resuscitate your mother, which normal people sound as, well, you want my mother to die? No, you need to talk about what you're going to do and what you're not going to do, but present it in terms of a solid recommendation of the care that you plan to give to the people. Does that make sense, Kevin?
Well, it does to me, because we've talked about this, and I think your opinions are excellent. They exactly coincide with my own. But I think that when I'm in this situation, and in response to the earlier question, who's the best person to talk about it? The best person to talk about it is the best person you have. And that may vary. Sometimes our palliative care people are excellent. Sometimes they're not. Our ICU people can do this very well. Some of them don't. Some of our ethics consultants have been called on this to have this conversation. When we do, usually, ideally, in the context of a goals of care discussion, we do exactly what you said. We tell them what we think we can actually accomplish for their loved one. I don't like to ask them, do you want us to resuscitate them or attempt resuscitation? It sounds more like resurrection. And in fact, I think that we tell them what we don't think will work. Then the crux becomes, if you say we're not putting that on the table because it's really not going to be beneficial or effective, what do you do when the family pushes back really hard? Typically, they don't. Typically, you'll find people who say, you know, we want to do what's good for them. And they I think, appreciate having the burden taken off their shoulders of saying, we're going to place a DNR. But the big problem pre-COVID and now during COVID is what would happen if the families push back on that. I think we have one of two approaches. We just tell them, essentially, we're going to do what we just said, irrespective of your wishes, or we try and negotiate to get to the point where we are without imposing the do not resuscitate order immediately. What do you do most often?
I really don't like being unilateral and high-handed. And I often I think it's important that when you tell somebody about resuscitation, they think it's like on a cold morning when you get your car jump-started. And when you're talking about not resuscitating a family member, they think you're the jerk who drove by and wouldn't help them start their car. In this particular situation, I think it's important to explain why you believe it would not work, and without being inappropriately graphic, to explain that it is a procedure that is relatively violent, that does have a high burden and very little benefit. And to also make a strong recommendation that I really believe what I've offered is the best care possible that we have these days, and that to continue or to have an aggressive resuscitative effort would not be appropriate and would perhaps increase the risk of suffering without the likelihood of a good outcome.
I think that something else that you've mentioned already just needs to be underscored and emphasized, and that is the real low probability of success for most patients, even in the hospital. In the best of circumstances, it's an 80% failure rate to resuscitate people and get them out of the hospital alive. People don't expect that. They expect it to work. And we all know why they expect it to work, because they've seen it work repeatedly on television and in the movies. But it works poorly in the hospital, and it works much worse in the ICU. I have told our students that if they were ever to experience a cardiopulmonary arrest, the safest place for them to do it would be on TV.
Right. And we need to realize that our discussion now is influenced by COVID, one, because fear of infection of healthcare workers. The second is because of all the stress on resources, including beds, ventilators, etc. The third thing to realize is that these discussions are not all that different than they were before the COVID stuff happened. The only thing that I could think would make it a little different is some patients have a COVID-related myocarditis, which makes it even harder to resuscitate them and even less likely it would work. So again, it's important to use individual judgment about the likelihood of a treatment to work. As Dr. Pellegrino would say, you're trying to do the right healing action for the person. On the doctor's part, that involves looking at what you know from medical knowledge and trying to adjust that to the patient's achievable goals. If a patient wants to live forever, that is not an achievable goal.
What you're telling us is that good ethics is based on good medicine, which I think no one's going to disagree with. How is this particularly Catholic in this presentation?
Well, let's take a look. We look at individuals. We don't look at broad groups. We recognize that simply maintaining a heartbeat is not the goal of respecting life. We're not vitalists. We endeavor to care for all people, and again, don't lump them into groups. We want to make sure that we pay attention to relevant factors and do everything possible to risk discrimination and marginalization of some. We also care for our healthcare workers. And I said that might mean it's going to take a little longer before the code can start. And an infectious pandemic means extra care in trying to minimize even unavoidable risks. And again, over and over, I've said, we don't do these things ad hoc. Catholics are people who believe in human dignity, but they also believe in community and the common good. So we consult and work collaboratively to ensure good care, fairness, and learning from what we do.
It sounds like a good plan to me. I think that hopefully we can move forward along these same lines. And I thank you, Dr. Sheehan, for participating with us today and giving us your wisdom.
Thank you so much.
Now our next participant, also a member of the Pellegrino Center for Clinical Bioethics at Georgetown, is also a physician ethicist, and he didn't oversleep. He's not showing up in his pajamas. He is, in fact, a intensive care attending physician and has made time in his incredibly busy day today to sit with us and talk about our next topic, one that he is uniquely suited to discussing, because we're talking about ventilators and the reallocation of ventilators, especially in a pandemic situation such as we have today. Welcome, Dr. Roberts.
Thank you, Dr. Donovan. Can you see me and hear me?
You look terrific.
Thanks.
All right.
Oh, shucks.
So let's talk about ethics in a pandemic, just in general. You know, pandemics create extraordinary circumstances, not just medical, but economic and social. And they put burdens on the healthcare system, on patients, and those who are trying to take care of them. Some tell us that the extraordinary circumstances require extraordinary responses to conditions that threaten to overwhelm our resources. We would argue that in challenging times, we must depend on our ethical values, principles, and traditions more than ever. Circumstances shouldn't change our ethics, but our ethics should help us deal rightly with our circumstances. Now, we have both agreed on these as general principles, but we're dealing with a specific epidemic that has some unique characteristics. Do you want to tell us a little bit about that?
Sure. So first of all, as everybody is probably very well aware, this is a unique situation with COVID. I've told people many times, this is a vicious disease. It's extremely contagious. Maybe 25% of patients will be asymptomatic carriers and transmitters of the disease. And the spectrum of illness runs the gamut from asymptomatic carriers to patients who have respiratory failure, pneumonia, multi-system failure that follows that. There's an extremely high mortality rate in patients who are greater than 65. I think I qualify. And they're also on the vent. Death, however, can occur at any age. This is no respecter of youth and vitality, this disease. And sudden death may occur following an initial improvement in the respiratory status. There's a higher incidence, sadly, in patients of African-American lineage and other minorities, and those who are afflicted with, as we say, comorbidities, other diseases in the mix.
Now, Alan, you just scared the pants off everybody. However, can we also remind them that 80% of the people never get a chance to see you, that they actually go through this at home?
We can say that, yes.
All right.
No, if you don't want to look up and see me as your doctor, that's for sure.
I'd be delighted to see you as my doctor, but I don't want to be in the ICU.
Yeah, okay, me too. Okay, so next slide, please, sir. Okay, I just want to make a couple of comments on how we do things a little bit differently for patients with COVID disease who are developing respiratory failure. And we do this, we have an ethical duty to protect our caregivers as unique individuals who are created in the image of God, but also as people who we want to be available to continue to serve in this tragedy here. So we want to care for the patient and protect the caregivers. Consequently, as someone gets into respiratory failure, we will actually avoid certain non-invasive forms of ventilation. You may have heard of CPAP or BiPAP or non-invasive ventilation. And these modalities that we would use in non-COVID patients can actually cause aerosolization of the virus and disease transmission in COVID patients. So we will go earlier to intubation in patients with COVID disease, not just because of the CPAP aerosolizing the virus, but also we want to intubate patients during a period of relative stability. We know the direction they're going in, but we want to get to them before they hit a crisis mode, controlled environment. We'll just get them intubated more safely. We have a dedicated team of anesthesiologists to come up and do precisely this. We minimize the number of people in the room, maximize efficiency. We get in, we get out.
One of the things that we probably ought to admit at this point is that trying to treat COVID is still a moving target. And in fact, how you manage the vents and whether or not you even want them on a vent is still being discussed about the various intensive care physicians. Isn't that right?
Yes, sir.
Well, that certainly has an impact on things like resource allocation, you know, and everybody has been talking about the important issues there. The personal protective equipment, as you mentioned, is crucial. So are medications, and not just the things that we hope will be effective in treating patients, but the medications that you are using on your patients every day just to keep them on the vent and keep them comfortable and keep them from fighting the vent. We also have to remember hospital beds. You see them setting up tents outside hospitals and in the parks. I know you're working on extra hospital situations that may be needed in your locale. We can't forget that the trained professional personnel are crucially important. You could have an abundance of vents and even an abundance of doctors, but unless they're trained to manage these vents, you're still in trouble. So we talk about the procedures, we talk about the equipment, of course, but what we're going to talk about today is particularly the ventilators. To the next slide.
So, right, and I think that Miles mentioned a couple of minutes ago something, I think the term was proactive ethics and whatnot, and one of the things I think we can do proactively as ethicists in the hospital, taking lessons learned from COVID going forward, is to put in place, I'm just going to touch the second bullet first, before the crisis hits next time, and we think there will be a next time with something else maybe, we need to develop a scheme for how we're going to allocate resources. Before we allocate, before we limit access to resources, we want to think through the varieties of resources that actually we have under our roof. For example, we have, as many places have, canceled elective surgeries that would require anesthesia machines or possible ventilation post-operatively. We haul out those anesthesia machines. We share resources with regional hospitals. We want to, actually, there's a number of places in New York that have worked with ventilators to attach between 2 and 4 additional patients to a ventilator. So there's a lot of ways we can advocate for resource innovation before we get to the problem of possible reallocation. Additionally, and we should be doing a better job of this even on a good day without COVID, but we want to look at patients up front as they come in who simply will not benefit from mechanical ventilation. Pre-existing conditions, acute crisis, massive trauma, and we want to think through very carefully as we discuss with the families in a compassionate way before we inflict a ventilator on a patient for whom it will render no benefit. But then, of course, there's the consideration of removing individuals from the ventilators after all these avenues are exhausted. And what about removing a patient from the ventilator, but without consent of the patient or the family?
Alan, that's really important. But before we go there, we've had a couple of people already asking you, some of the issues that I know we don't have all the answers for yet. What about the management of these people on the vents and proning them and, the various interventions? One of the questions was, if you go on a vent, how likely are you to come off alive?
Well, it depends on your age and the number of comorbidities. The data that I've seen consistently over time is that in patients over 65 years of age, 80% do not come off the ventilator. 20% do. The younger you are, the fewer illnesses.
To clarify, you're speaking now of patients who are on the vent with COVID.
Yes, COVID patients, yes. COVID is basically a disease unto itself, different statistics than all others. The vast majority of patients that we put on the ventilator have a relatively rapidly reversible process. We get them through it, and we bridge them to a state of recovery of their pulmonary function. We can get them off the ventilator. In older patients, and especially patients with additional diseases in the background, going on the ventilator It's a longer course on the ventilator. The disease does not resolve as rapidly as, say, a community-acquired pneumonia. And they're stuck on the vent. And the older they are, the more comorbidities they have, the less likely they are to survive. Younger patients tend to do better, but it's still not a quick time on the ventilator. It's not a rapid turnaround.
Okay, well then that brings us to the question of triage. And many of our listeners would know that triage is a French term, came out of Napoleon's army. It is the assignment of degrees of urgency to decide the order of treatment for a large number of patients. It's a military term. I know you were in the military yourself, but now you're in the ICU. Is there any difference?
Well, no, yeah, we do triage every day. And many people in many types of jobs do triage. What's the priorities that come to your desk, for example? But every day in medicine, we triage patients. We allocate our time. We change focus. All of this is sort of an intrinsic reflex triage. It's based solely, this is important, solely on clinical and circumstantial criteria.
Okay, well then the criteria, the approaches that have been suggested for triage in a pandemic would include things like first come, first serve. Maybe we ought to have a lottery. That seems fair if you win it. About the urgency of need, we look at that on a daily basis and the kind of triage on a daily basis that you were describing. What about the likelihood of survival? Short-term survival has always been an important consideration in patient care. What about long-term survival? People that are, predictably going to live for a very long time, well beyond 12 months once they come off the vent if they were to do so. And then we could also talk about the likely benefit. And these are some areas that have really been somewhat of concern to a lot of people.
Sure.
Can we look at their expected lifespan, their previous health, the benefit to society? Now, one of the things that we will stipulate right now, because there have been some questions about this, and how do these criteria apply? How are they unfair or fair? What about the exclusionary criteria? How do they even relate to the ERDs? Happily, Dr. Dan Solmacy from Georgetown will also be talking about this in one of the two sessions that we have planned for next Thursday. So it's not that these questions aren't important, but we will spend a much larger period of time looking at those exclusively. Let's talk now a little bit about the guidelines and frameworks for this allocation. And the rationing criteria have to start off with deciding, as you've already mentioned, Dr. Roberts, who's eligible, because there may be some people who just shouldn't be eligible for their sake. What are the disqualifying conditions? And these scoring systems that we'll have Dr. Solmacy review for us next week. Clearly, it has to be done with transparency, and that's one of the things that we found concerning, that many of these protocols have been suggested without necessarily being publicly advertised what those policies are going to be. But finally, the most disturbing, troublesome thing about it all are these reallocation policies. So kind of walk us through that, if you would.
Well, I think that, as you say, they're disturbing because many of the criteria for rationing include reallocation of a ventilator from one patient who's currently on that ventilator to another seriously ill patient who needs one. We don't do this on a daily basis. This is sort of out of normal practice, and it should catch us as a little bit disturbing that someone will remove a ventilator to give it to someone else. We are fortunate to live in a time of great abundance, but we're talking about the hypothetical that I hope never materializes of scarce resources. How would that be? And by what criteria would we make that awful decision? Would it be, for example, a better chance of survival of the other patient? Fewer comorbid conditions. This person has 6 diseases on the ventilator. Perhaps the patient who's waiting for the ventilator only has 3 diseases. Is that supportable statistically in the literature? Does the patient waiting for the ventilator have a better neurological status, either at the onset of disease or predicted? Is the patient pregnant? If they're pregnant, do they already have children? And therefore, should we put them lower on the list, for example? Is it a first responder or a patient who's on the front lines? These are things that are being floated and they're concerning to us. Now, you know, as in all good military tactics, we want to be able to understand the rationale of the people that we disagree with. And the justification for this sort of reallocation proposal has been based on just a flat notion that, well, triage is intended to save lives, the greatest good for the greatest number of people. And we should not allow, according to their line of reasoning, patients with a more hopeful prognosis to die when those who are less likely to survive are taking up a perfectly good ventilator and hogging all the available resources. We have a problem with this. I have a personal problem with this. It's this thing of relativized sacredness in my mind is the way I think about it. Is this ethical? Is it even legal?
Well, let's look at some of the ways reallocation can occur, some of which I don't think you're going to be very disturbed by. That first one. Yeah.
So, you know, we have this thing called advanced directives. We think about this all the time. You know, if someone, and there's actually cases of this in the COVID crisis where I went to talk to a patient a couple of weeks ago. We believed him to have COVID. He was on precautions, and I explained to him that we were going to be intubating him. And the first question out of his mouth was, "Doctor, are there enough ventilators? I don't want to take a ventilator that might benefit someone else." Well, God bless him. So at that time, you know, we had plenty of ventilators. We were able to get him on the ventilator without that concern. But
some of our viewers, Alan, may even be aware of the new push to kind of codify what you just described. And there is a form being distributed called Save Other Souls that we've just learned about that would actually act as almost as a codicil to an advanced directive that would only be active during the time of this pandemic.
Yes.
And just exactly what you said. I'm assuming that doesn't bother you too much.
You know what? I think that's fine as long as it's informed and as long as the patient has capacity. But then the family or the surrogate decision maker can speak similarly on behalf of the patient. What we're concerned with is it not being voluntary or made by good faith surrogate decision making, but rather having a program of reallocation handed to us by some authority.
Okay, let's focus on mandatory reallocation by the medical team without permission or consent from the family or the patient.
That is correct.
All right, well, that is quite problematic. One of the things that this does is actually turn the physicians and the hospitals into agents of the government with due process requirements and liability protection. You know, you did ask the question, is this legal? And I think that most of your legal consultants might say it's of questionable legality to take somebody off a ventilator who might still be benefiting from it and hand it to somebody else because of our estimation that they may benefit more. Now, we know from what you've already said that the benefit is not guaranteed. And there are long odds against anybody going on a ventilator, particularly with COVID. But, you know, we're going to have to decide who should get that ventilator if we take it away from somebody who's already on it. We would have to have criteria, and they would have to be narrowly drawn. We would have to have triage procedures that would satisfy due process and be transparent. It would have to have some sort of appeals process that would be made available, and that would have to be almost immediate. I mean, there are going to be some problems, not just in deciding who might be getting the greater benefit, but then even how this could be done in some sort of just or ethical fashion. Let's go to that next slide.
Sure. So and this is the sort of question that we might come up with. I won't work through each individual case in great detail, but suffice it to say that according to these triage guidelines that are in place in law, have not yet been pushed forward because so far we have sufficient resources. But for example, if you have on the ventilator a 78-year-old man with COVID-19 disease, he's been on the ventilator for going on 10 days. He has no significant comorbidities prior to his illness. He was a jogger, worked full-time, has not made significant improvement, however, in spite of everything we're doing, which we believe we're doing correctly. And he's developing kidney failure as a complication. This is going to require him to go on our continuous dialysis protocol. And then they bring in a patient who's 22 years old, for example, admitted to our service a couple of days ago, also with COVID-19 disease. And his respiratory status is getting worse on the high flow nasal oxygen. And we are getting into that protocol where I mentioned before that, we do have to intubate this guy sooner than later for a variety of reasons, both his interests and the interests of healthcare givers. And these protocols that are coming down the pike would ask us, actually they wouldn't ask us, they would tell us to make the decision to take this older gentleman off to provide the ventilator for the younger gentleman.
It looks like a slam dunk, doesn't it?
You know what? It's the way they frame these things is in many ways seductive.
Well, you and I have also looked at this one together and decided that first patient that we might remove from the ventilator for the sake of that second patient might describe our colleague that's known to many of the people here. But Tony Fauci sounds a lot like that guy, except thank God he doesn't have COVID.
And he doesn't have renal failure, and we pray for Tony on a daily basis around here. We like that guy.
Well, let's look at another pairing.
Okay, so just to flip the age thing a little bit, we might be asked to choose between a 35-year-old African-American man with acquired COVID. He's obese, he's got comorbidities, so obese, hypertensive, diabetes. He's slowly deteriorating for the past 8 days, and he's showing signs of additional organ failure. He may need to go on to ECMO. ECMO is an advanced technology for oxygenating the blood apart from the ventilator. It's not available uniformly in all institutions. It requires a different technology. But we have this young man who is getting worse. Or we have to choose between this man and a 65-year-old nurse who acquired COVID-19 while working 12-hour shifts in the ICU. Despite the fact that she's had multiple sclerosis, she continues to work. Now, here's someone that we would like to default to because she's a nurse, she's one of us, part of the team. She does have comorbidities, but you can see these two hypothetical patients are somewhat nuanced. How do you choose between these patients based on clinical criteria, or do you have to invoke some of the non-clinical, non-objective paradigmatic thinking that is handed down to us, years lived, age, etc.
And these, once again, are the issues that we will have on the table in the discussion that we're leaving up to Dr. Somesi. He'll even talk about things like, can we use the SOFA score? Should we use an Apache score instead? There are so many issues about the criteria. And I think we're looking at this one saying, this is just not a clear slam dunk to anybody.
No.
It's not really clear that any of the various reallocation criteria would not unfairly disadvantage somebody. It brings us back to the whole idea of triage, but the difference between the kind of daily decision-making in the ICU that you first described and the kind of military triage is that, in fact, triage in a military sense and in this pandemic sense is we are not pretending in that case to benefit the patient at question. We are trying to benefit a larger number of other people. And, and in military triage, put them back up at the front lines. It's not considered necessarily a great benefit for them as well. So let's look at some of the arguments against this. You know, it's pretty clear, especially from that last case, it's not going to be a very practical approach. It's going to take a lot of time to reevaluate them according to whatever criteria you decide are just and fair and ethical criteria. You would have to know who's going to do badly. And I think particularly in this case of the COVID pandemic, are you really comfortable in making that call early on people? Or is this just something that we're still working out?
You know, I think we're early in the COVID thing. I think that you know, how we do this, how we take care of COVID is going to be in some measure, in large measure, guided by what we ultimately learn about this disease, and we're not close to that yet. But in terms of making a decision about a ventilator to keep this patient on or to move it to someone that we think either has a better chance or has some other than objective life quality criteria which we have imposed, I don't think we should be doing anything differently.
Well, and you did kind of allude to the problem of, you know, who would be getting these and who would we be taking them from. Now, some people think that, oh, just looking at all those comorbidities that you described, well, that's subjective. But we specified that the patient, who actually did reflect a real patient, was African American simply because they are more likely to show up with all those comorbidities as a matter of the social injustice that's already present.
Yeah.
Somebody asked what would be the race of the nurse, and would that be pertinent as well? And I think that, you know, we're starting to get into the complexities. We could even add another complexity that's on the list there. Let's assume that we felt comfortable taking the ventilator away from that man because we thought, well, you're just not doing well enough, and we'll give it to somebody else. Well, what happens if she doesn't do well enough and somebody else comes in and we still are short of ventilators? Are we going to take it away from her and pass it on to somebody else after appropriate cleaning? I mean, where really do we find the endpoint of this, or does it just get overly impractical? And beyond the practicalities, you know, this becomes unfair to the patient on the vent who may still have a chance. It's truly destructive to the patient-physician relationship. It will destroy trust when people are thinking, when they turn themselves over to you, that they can trust you to do the best for them. And it's clearly going to be discriminatory to the disabled, those on home vents, for instance, who would be afraid to come to the hospital for fear that they might lose theirs if they have other issues that the patient in need doesn't.
I might add to that, Kevin, that I'm sure you're aware that the disabilities rights groups have weighed in big time on this precise eventuality. For those precise reasons. So let's take one last look at the ethics of this. You know, a pandemic is a crisis, but that doesn't mean that our ethical standards are dismissed. The goal of a right healing action for an individual patient needs to be respected, even if there may be decreased options, and rationing schemes have to be cautious because of the danger of discrimination against everybody who's already disadvantaged. And the protocols have to be clear and shared among all practitioners and subject to review, and minimize that ad hoc decision making. I think if we can get ourselves to that point, that we will not look back on this and ever hang our heads in shame no matter the outcomes. Dr. Roberts, you did a great job. You were very helpful.
Well, thank you. I just wish I had the same presence as Sanjay Gupta, but I'm going to work on that.
All right.
Thank you all.
And this concludes our meeting for today. Thank you.
All right, very well. On behalf of the Catholic Health Association and Georgetown University, I want to thank you for your participation in our event. A recording of this event will be sent in an email. It will also be posted on CHA's website, www.chausa.org, coronavirus. This concludes our program for today. Thanks, everyone. Have a great rest of your day.